The following podcast is part of a certified educational activity. Access the entire activity and complete the post test at peerview.com/GKC860. Downloadable slides and practice aids are also available.
Hello, and welcome to our virtual symposium, the Pathology Oncology Partnership in AML, Identifying and Treating the Diversity of Disease Subtypes. I am Dr. Joseph Corey from the MD Anderson Cancer Center in Houston, Texas. I am delighted to welcome my colleague from MD Anderson, Dr. Naval Daver. Dr. Daver is an expert in acute myeloid leukemia, and we work very closely on treating patients with this disease. Thank you for joining us. This is an overview of today's agenda. The format for this activity is a tumor board style presentation, where we would like to capture the features of high-risk and mutation-defined AML. We're going to discuss diagnostic principles for the various subtypes of AML, and we're going to importantly focus on how diagnostic assessment improves treatment decisions for AML with myelodysplasia-related changes, or AML MRC, and FLT3 mutated AML. We're going to also discuss evidence on the novel therapeutic approaches that are making a dent in the outcomes for patients with AML across various subtypes. We're going to start with two case presentations and then have some didactic slides kind of focusing on topics related to today's theme. And then we're going to come back to these patients and discuss how their management will be impacted based on a combination of pathology and oncology considerations. The first patient, Barbara, is a 63-year-old woman who presented with fatigue, low-grade fever, and discomfort for 2 weeks. At that time, or shortly thereafter, she was diagnosed with acute myeloid leukemia. She had an ECOG performance score of 1 and had a history of hypertension. When she presented to our institution, she had a bone marrow examination which showed AML with a background that is significant for multilineage dysplastic changes. Her bone marrow had 54% blasts that were CD33 positive. She had no prior history of antecedent hematologic disorders or prior exposure to chemotherapy or radiation therapy for other types of cancers. So the questions around this case are, what additional information should be collected in a case like this by the lab team, by the pathology team, and what tests should we recommend? What translocations should we look for? What mutation types should we look for?
So I'm happy to kind of discuss some of those points from a clinical point of view. I think for this patient, the key information that we would need would be, as Dr. Khoury was mentioning, cytogenetics, especially core binding factor cytogenetics in version 16, translocation 821, because we would consider addition of gemtuzumab if there was an identified core binding factor leukemia. Molecular mutation information would be very important, FLT3, FLT3, and IDH1, IDH2, as we may consider addition of targeted therapy to frontline treatment. And more now we're looking for the presence of TP53 mutation, because there are particular therapies that are showing early but high efficacy in TP53 mutation. And then we would also like to look for MDS-related cytogenetic changes, because there is a drug, CPX351, which is US FDA approved for patients who have MDS-related cytogenetic changes or therapy-related secondary AML. So we depend heavily on our pathology and molecular colleagues to provide this information. As you can see, there could be up to 5 different potential treatment options.
Great. Thank you, Naval.
Thank you, Joe.
So the second patient is Mr. Robert, a 53-year-old man who presented with newly diagnosed pancytopenia and diagnosed with AML with a diploid karyotype, a FLT3 ITD mutation, in addition to mutations in NPM1, DNMT3A, and TET2. The patient received 3+7 induction with midostaurin and achieved clinical remission post-induction. He received 2 consolidations with high DAC, followed by a mud stem cell transplant. Post-transplant, he was not placed on maintenance inhibitors for FLT3. He did well for 7 months, but presented currently to our institution with new onset of severe cytopenia. He had a bone marrow examination done at MD Anderson, where we were able to confirm AML relapse with 60% blasts, diploid karyotype, and confirm the presence of a FLT3 ITD mutation, in addition to the other mutations that were described at baseline. So Naval, of course, this is important information for you to determine what steps to do next for this patient. But what additional information is needed to select optimal therapy for this patient, in your opinion?
Yeah, I think for this patient, we have most of the information that I would need for treatment. I think the key factor here is to look for the presence of FLT3 mutation at relapse and confirm that the FLT3 is indeed still present at relapse, because we do know that about 15 to 20% of patients, based on published data from our groups and others, has shown that the FLT3 mutation may be lost at relapse, especially after receiving FLT3 inhibitors such as midostaurin. So we always confirm the presence of FLT3 at relapse, and this person does have a FLT3 ITD with a high allelic ratio 0.56. So he would be a great candidate for FLT3 inhibitor-based therapy using the FDA-approved drug gilteritinib, which has shown high efficacy that we will discuss in the later part of the presentation. Thanks, Joe.
All right, so for the first portion of the presentation, I would like to share with you how the principles for capturing high risk and mutation positive AML. And as we mentioned, the second portion of the presentation, Dr. Daver will present novel therapeutic approaches for patients in these disease groups. This is a very broad overview of the diagnostic milestones in that patients who have AML or are suspected of having AML will go through. Basics, history, physical examination, assessment for comorbidities, and then basic labs, CBC with a differential and a chemistry profile. It is also important to remember that patients who are diagnosed with AML or suspected of having AML are routinely assessed or should be routinely assessed for possible DIC and coagulation disorders. After that set of baseline studies and data is collected, the patient is then evaluated with bone marrow examination. At MD Anderson, we have a dedicated clinic that performs bone marrow sampling. That includes a core biopsy or a trephine biopsy, in addition to a clot preparation at our institution. We also prepare aspirate smears, we prepare touch preps, and we secure samples for flow cytometry, cytogenetics, and molecular diagnostics. This is on a routine basis. In addition, the patient is typically assessed or HLA typed if they are a potential candidate for stem cell transplantation. And we perform CT and MRI to assess for CNS involvement, as well as a lumbar puncture. I am also reminded that there's always a need to assess for myocardial function in patients with a history of possible cardiac disease prior to exposure to cardiotoxic drugs or potential exposure to radiation of the thorax. This is an overview of the diagnostic categories in the current 2017 WHO classification of AML. I will not read through all these categories, but it is important to note a few salient aspects. One is that AML with recurrent genetic abnormalities as a category includes some entities whose management is very specific and thus need to be recognized as early as possible, ideally. None is probably more important than recognizing acute promyelocytic leukemia, or AML, with translocations involving PML-RARA, like 15, 17. These patients do not receive chemotherapy. They have to be closely monitored for possible DIC and need to really be teased out from other patients who have AML. The other important category, and one we will spend time on today, is AML with myelodysplasia-related changes. And we will spend some time discussing why this is an entity that needs special attention. This is I would say, a simplified, relatively simplified algorithmic approach to AML diagnosis. Diagnosing AML has to start with morphologic examination. Morphologic examination can begin in a blood, peripheral blood smear, but that is not enough. We do need to evaluate the bone marrow, of course, and do a thorough morphologic examination of the bone marrow. As part of that evaluation, we need to look at the blast count. We need to look at the lineages that are not blasts, assess all three lineages: erythroid, granulocytic, and megakaryocytic. We also need to understand what the microenvironment in that bone marrow looks like. Is there fibrosis? Is there anything else that might be going on? And then, based on that evaluation and a determination of at least 20% blasts in the blood or bone marrow, a diagnosis of acute myeloid leukemia is done. At MD Anderson, we still perform myeloperoxidase cytochemistry. The importance of MPO is several-fold. If it's very highly expressed in all blasts, then we often and have a low threshold for suspecting acute promyelocytic leukemia. And that would trigger a series of tests to either confirm or exclude APL. If MPO is between 3% and 20, 30, 40%, then that would be a standard AML, and we would manage it or manage the diagnostic workup accordingly. Importantly, if MPO is negative, and by definition that is 3%, that is under 3%, then our flow cytometry and some additional workup is also geared to excluding acute lymphoblastic leukemia. And as I mentioned earlier, our evaluation of any patient with AML includes molecular studies, and that includes next-generation sequencing, based mutation profiling, flow cytometry immunophenotyping, conventional cytogenetics, and as needed, we add FISH assays. Prognostic factors in AML are quite complex. There are pre-treatment characteristics, and there are some post-treatment predictors. Among pre-treatment characteristics that play an important role, and this ties in with what Dr. Daver mentioned at the outset of this presentation, is cytogenetics, age, whether the leukemia is proliferative or not, and that's measured by the WBC. Is it very high or not very high? Are we dealing with a secondary or therapy-related AML? Is FLT3 mutated or not? Is NPM1 mutation there or not? Is EBPA mutation present or not? In addition to all of these, there's also a myriad of other factors that today are shaping, better than ever before, our ability to risk stratify patients with AML and determine whether they might be eligible for certain therapeutic approaches. And we will discuss this in some detail, and Naval will go into quite a bit of detail on some of these themes. I'd like to spend a few minutes talking about AML with myelodysplasia-related changes, or AML MRC. The diagnosis of this subtype of AML, of course, requires the presence of at least 20% blasts in the bone marrow or blood. But then there are some exclusions. This is a diagnosis of AML MRC should not be made in a patient who has an NPM1 mutation. So by definition, an NPM1 mutation excludes AML MRC. And also excluded are patients who have biallelic mutations of CEBPA. Patients with a history of MDS or MDS-MPN who develop AML are also labeled as having AML MRC. Another pathway to get at this diagnosis is through MDS-related cytogenetic abnormalities. There is a well-defined list of abnormalities that have been understood to comprise a standalone criterion for making a diagnosis of AML MRC. Importantly, in the new WHO classification, deletion 9q is no longer one of those criteria. Importantly, AML MRC is also excluded in the presence of known translocations associated with AML or known recurrent cytogenetic abnormalities associated with AML. And importantly, AML MRC cannot be a designation in a patient who has received previous chemotherapy or radiation therapy. So based on all of this, we can then say that there is a group of tests that will be needed before we establish a diagnosis of AML MRC. This includes cytogenetic analysis, flow cytometry, molecular, and importantly, mutational analysis to assess for NPM1, CEBPA, and RUNX1 for patients who do not already have evidence of core binding factor AML or acute promyelocytic leukemia. And again, to do all of this, it has to be done in the context of a bone marrow evaluation where we also look at the morphology of the three lineages aside from assessing the blast percentage. AML MRC can be a challenging diagnosis. Our group recently published a very nice overview of this entity. And there are some aspects that can make this diagnosis a bit easier or can support this impression in terms of diagnostic workup. Flow cytometry is one of them. At our institution, we have a panel where we can assess the maturation patterns of the various lineages in the bone marrow. It's our MDS panel. When we suspect AML MRC, sometimes we add an MDS flow panel, and that can help us further evaluate for possible dysplasia and maturation abnormalities. Sometimes AML MRC can be subtle. It can be against a background of what seems to be like MDS, high blast MDS. And so doing immunohistochemistry, particularly for CD34, can be helpful in that context to demonstrate that there is indeed quite a bit of blasts exceeding 20%. Importantly, as we mentioned earlier, the pathway to make a diagnosis of AML MRC are several. One is based on morphology, where we as diagnostic pathologists would be looking at the smears and looking at the bone marrow H&E slides and determining that the lineages show significant dysplasia across the board, and or at least in two lineages or more. That can be a bit subjective. Sometimes it's a bit difficult to do it, particularly if a patient has received maybe 1 or 2 courses of therapy and is then referred to be reassessed at a different place. Another pathway to get to AML MRC is, of course, by cytogenetics, where we look at the bone marrow, it looks like a standard AML, and then we get cytogenetics and it shows a deletion 5q or a -7 or a 7q minus. In that case, it's AML MRC based on that. Or if the karyotype is quite complex, i.e. more than 3 abnormalities. And last but not least, another pathway where a patient might end up being labeled AML MRC is by virtue of having had a prior diagnosis of MDS or MDS-MPN. Importantly, our analysis has shed some light on the mutational profile of AML MRC, and as you can see from the figure here, that is topped by mutations in P53. In addition to mutations in ASXL1, NRAS, and DNMT3A. Importantly, if one analyzes those various subtypes of AML MRC, i.e. AML MRC is based on various criteria, one recognizes that it's not a high-risk AML across the board. So Naval and of course the leukemia team at MD Anderson know this so well, and they tailor their management accordingly. This is the list of cytogenetic abnormalities that by themselves, regardless of what the morphology looks like, these findings make it or make a case AML MRC, again, in the absence of NPM1 mutations, in the absence of a history of cytotoxic therapy, and in the absence of recurrent cytogenetic abnormalities. As you can see here, these include complex karyotype, more than 3 cytogenetic abnormalities, and a group of balanced and unbalanced chromosomal structural changes. It is important to note that actually the majority of patients who have AML MRC have it without an antecedent history of MDS or MDS-MPN. Another aspect to keep in mind is actually illustrated by this example, and that is the impact of prior treatment on bone marrow morphology, which in some areas, without knowledge of the patient's full history, might actually mimic AML MRC. One example is patients with FLT3 mutations who receive FLT3 inhibitors might sometimes have their blasts undergo enough differentiation, and that differentiation is often associated with dysplastic features that picture might raise the possibility of AML MRC, at least on a morphologic basis. We see a similar situation in patients with AML who receive IDH inhibitors as well. IDH inhibitors are very well known now, have been well established to induce differentiation. And so without knowledge of prior history of some of these therapies, we might inadvertently label a patient as having AML MRC, when in reality it's the dysplastic changes are due to other factors, sometimes iatrogenic. Now, I'd like to pivot a little bit and talk about the detection of genetic mutations in AML. Certainly, the NCCN recommends bone marrow analysis with cytogenetic, conventional cytogenetics, karyotyping with FISH. But in addition to that, there is definitely a need to assess the mutation status of a core set of genes that are now part of the WHO classification in various ways for patients with AML. These genes include, at a minimum, KIT or c-KIT, FLT3, internal tandem duplication, FLT3 tyrosine kinase domain mutations, NPM1, CEBPA, IDH1, IDH2, and P53. So this is an overview from, or a nice, at least schematic, that demonstrates the clonal evolution or clonal journey that patients with myeloid neoplasms or myeloid proliferations, including AML, go through. And importantly, it demonstrates schematically again, the impact of mutations and how relapses that might occur following targeted therapies and the context of certain mutations might look like. Importantly, without going into the details of this figure, what it underscores is the need for vigilant and thorough monitoring for patients with AML, not just at baseline, but also throughout their disease course and throughout their journey with this dreaded disease. One of the important platforms that has really made a big difference for monitoring patients with AML in terms of their response to induction therapy is minimal residual disease evaluation, or measurable residual disease evaluation using flow cytometry. Discussing this area in detail is beyond the scope of this tumor board style presentation. I would just only like to underscore that AML MRD is quite powerful. It allows us to achieve sensitivities that are in the range of 1 cell in 10,000 cells. And it allows us to do so in a manner that is fairly practical from a turnaround time standpoint. We can do MRD evaluation within a day or two from getting a bone marrow sample. This provides important information, at least quite important for patients who come to our institution in clinical remission, who are seeking answers or guidance or treatment for managing that next step in their disease management. So as we mentioned then, in addition to thinking of AML MRC, and as part of the differential diagnostic considerations is considering AML with NPM1 mutation. NPM1 mutation by itself defines a unique type of AML, and it also, now we recognize, also defines a unique type of MDS and MDS-MPN patients, as we detailed in a recent publication in Blood Advances led by Montalban Bravo from our institution. Importantly, NPM1 mutation confers a favorable outcome in patients with AML, but the presence of this mutation also is associated with significant dysplastic changes, and hence its potential overlap with AML MRC. So my recommendation is to be careful and not label a patient as having AML MRC before confirming NPM1 status in that given leukemia. So based on all of what we have just described, there has been slowly and steadily a move towards a genomic approach to the classification of AML. Certainly, if one adopts this approach, as was highlighted very elegantly in a landmark publication a few years ago, we see that AML with NPM1 mutation might actually lead the pack in terms of frequency, followed by various types of AMLs defined by either mutations or by translocations that dominate the biology of those subtypes of AML. And importantly, present us and present our oncology colleagues with therapeutic vulnerabilities that they can then target and attack for each patient on a personalized level. I will not read through all of this. You will have this information available to you. But thinking of AML as a genomically defined set of diseases under the big umbrella of AML might be the way to go for us. So I'd like to wrap up with this slide, really putting it all together from a pathology standpoint. We gotta, as pathologists and as members of a multidisciplinary team that treats patients with AML, we gotta plug our contribution into a big picture, of course. We do this on a daily basis, but we need to remind ourselves that in AML, probably more than many other diseases, this is quite important. So we gotta put together morphology, flow cytometry data, cytogenetics data, and molecular data to begin binning a patient in a particular disease category based on WHO criteria. Importantly, we have to put all of this in the context of what's happening in the bone marrow in terms of a microenvironment, fibrosis, is the patient immune compromised for any reason, and so on and so forth. And importantly, all of this has to be put in a clinical context that takes into consideration the patient's history, the patient's family history sometimes, and that is really the way to understand AML best and to share information in the best possible way collaboratively with our leukemia treating colleagues. So with this, I'd like to end my portion of the presentation, and I am excited to hear what Dr. Daver has to say about novel therapeutic approaches to these patients, these subtypes of patients with AML. Naval?
Thank you very much, Dr. Khoury, for the comprehensive overview of the pathology aspects of acute myeloid leukemia. Before moving on, I would like to see if we can field one of the audience questions. Let me pose this question to you, Dr. Khoury. Is there an optimal sequence for testing when you are trying to determine the presence of high-risk subtypes like AML MRC?
That's a great question. Thank you, Naval. The optimal sequence of testing for a patient with AML really ties in with the timing that some of the data is needed for treatment decisions. I would say that the best approach is to immediately send out a sample for cytogenetic analysis, for molecular profiling, and for flow cytometry. And then as the pathologist is looking at a case and examining it microscopically, typically within a day or so or two, flow cytometry data starts coming back. By then, I think the most important aspect in terms of sequence of data that need to be communicated is whether that AML we're dealing with is possibly acute promyelocytic leukemia or not. If it's not, then it is important to underscore some of the features of that AML, i.e., for example, the presence of background dysplasia. But I would not maybe give it a WHO classifier as of yet until the full set of data comes in. And when that happens, some of the initial treatment decisions could be managed. At MD Anderson, where all testing is done in-house, we are really fortunate to have an excellent turnaround time on all of these platforms. But I do recognize that this is not always easy, especially when one needs to send some of the work to a reference lab. So I would say most important initially is morphology, understanding if it's APL or not, or maybe one of the core binding factor AMLs. And then beyond that, if those are not considerations that can be addressed with a quick FISH test, then getting the data as soon as possible becomes a matter of about a week or so, ideally, for most assays. I hope that helps.
Yep, thank you very much, Joe. I think the key here before moving on is we always do all our testing in parallel. So we don't do it in sequence, which I've heard in some centers in Europe, because we want to get the cytogenetic, FISH, flow, and molecular all as quickly as possible. So the guideline usually, at least in our center, has been to send them all off, and some come quicker than the others. But if we do them sequentially, then that timeline may go on for 12, 14 days, which of course we don't want. So as you said, we do them all in parallel. So moving on, I'll kind of take those two questions that Joe had discussed in the beginning and highlight with some additional information that kind of becomes available to us at MD Anderson in about 3 to 5 days. So the cytogenetic panel usually comes back in about 3 days for us. And here you see that this patient who was a 63-year-old with reasonable PS, no significant comorbidities, and a bone marrow with AML with background dysplastic changes, and no prior history of hematological disorder, prior chemoradiation, now has cytogenetics showing deletion 5, 7, and deletion 17p. So clearly high risk and clearly cytogenetics that are known to be published by the WHO to be MDS-associated cytogenetic changes. And he also has mutations that have been known to be secondary AML-associated mutations. I will discuss some of that data in my presentation. These include SF3B1, ASXL1, and TET2. So I think in the community now, as well as in academic setting, we have questions as to what would be the optimal treatment choice for this patient. I will go through some of the emerging data. This patient being relatively fit, healthy, good performance status, no comorbidities, and having AML MRC, actually the labeled indication for which there is an FDA-approved drug based on positive phase 3 data is CPX351. Now, there is emerging data for HMA venetoclax, and it is FDA approved in general for older AML. However, the study population for that group was people above 75 or those with very severe comorbidities. So these are slightly different study populations, and I think we need more data for HMA venetoclax in this particular patient. However, some of the emerging data is quite interesting, and I definitely would consider allogenic stem cell transplant for this patient. I would probably consider CPX-based induction followed by transplant, which should hopefully give him the best chance of a long-term remission. Now, for the second patient, this was our FLT3 patient, younger adult, FLT3 mutated AML, received induction with 3+7 midostaurin, appropriately achieved the remission, and then received 2 consolidations followed by a stem cell transplant. Unfortunately, as we do frequently see with FLT3 AML, he relapsed post-allogenic stem cell transplant with a identified FLT3 mutation. So for this relapsed FLT3 AML, both ITD and TKD, there is a drug called gilteritinib, which has shown very encouraging activity that I will discuss more in my presentation, and is US FDA approved. And it is very, very important to try and identify FLT3 and IDH1, IDH2 mutated patients at relapse, because there are targetable therapy options that are more effective and safer, as well as oral options compared to intensive chemotherapy. And we will talk about some of those more through the presentation. So I'm going to be discussing some of the clinical aspects of acute myeloid leukemia therapy. As Dr. Khoury mentioned, we have very, very close partnership with our hematopathologist, flow cytometry, cytogenetics, and molecular colleagues at MD Anderson, and I will try to highlight how each piece of that data is clinically important to us for making the frontline treatment choice in AML in 2020. So this was the historical approach to AML. It was an easier approach, but it was not as effective as the approaches we're seeing today. And basically, the big dividing point was whether we felt a patient was appropriate or suitable for intensive chemotherapy or not suitable or high risk for induction mortality. And based on that, we would either proceed with anthracycline cytarabine based induction with or without stem cell transplant versus observation after induction consolidation. On the other hand, patients who we thought would have a high risk of induction-related mortality because of age, comorbidities, organ dysfunction, other features, were usually treated with lower intensity therapy, which included hypomethylating agents, low-dose cytarabine, and unfortunately, up to 40% of patients per the SEER database publication in the US from a few years ago were still getting no upfront treatment going to supportive care hospice. I think this will change with a number of new, better tolerated targeted therapies that we can give even in older AML. So what are the drugs that are approved? This is the list of agents. A total of 9 drugs have been approved in acute myeloid leukemia and a related disease called BPDCN, blastic plasmacytic dendritic neoplasm. These include targeted therapies such as midostaurin and gilteritinib, which are FLT3 inhibitors, IDH1 and IDH2 inhibitors, ivosidenib, enasidenib, and then newer agents, one of them being very, very, very important and effective, venetoclax in combination with HMA. I will discuss some of that data. And even for high-risk AML subtypes, such as therapy-related secondary AML, we have drugs such as CPX351 that showed improved survival in a phase 3, immune treatments such as gemtuzumab that we're using especially in core binding factor, and hedgehog inhibitor glastigib. So how do we approach all of these treatments, and how are we trying to personalize therapy in AML? So this is kind of a snapshot of how we would approach a newly diagnosed AML patient. So there are a number of different subsets that we want to identify because they have different treatments. So the first is acute promyelocytic leukemia, translocation 1517. As Dr. Khoury mentioned, if this is positive, these patients can go on arsenic and have an extremely good outcome, 96% survival. We don't use chemo or transplant for this population anymore. Core binding factor, inversion 16, 821. These people benefit from the addition of CD33 antibody gemtuzumab, almost 20% absolute survival benefit based on the published meta-analysis. So we definitely want to identify that. At gemtuzumab, our data suggest 5-year survival rates of 80 to 85%, so quite favorable group. And then for the others, we want to look for the presence of FLT3 mutation, TP53 mutation, and potentially, at least in clinical trial settings, IDH mutations, because we may be able to add targeted drugs, FLT3 inhibitors, IDH inhibitors, and possibly TP53 directed emerging treatments to improve the outcome. And then if the patients do not have any of these chromosome or molecular groups, we would consider the addition of other new agents, gemtuzumab, venetoclax. Also importantly, cytogenetics are quite critical. If we find MDS-related cytogenetic changes, we would consider the use of CPX351. So one is basically able to highlight here that there are 5 or 6 different frontline AML induction approaches. It's no longer one size fits all 7+3 for everybody, and each of these does improve the outcome and survival of the patient if appropriately selected. So let us discuss CPX351. This was a major advancement in treatment of a very high-risk group of AML. This is actually a chemotherapy formulation, but it causes increased penetration in the bone marrow and was associated with better survival, especially in therapy-related secondary AML and AML with MDS-related cytogenetic changes. So what was the data that led to the US FDA approval? This was the phase 3 study. Of course, there were preceding phase 1 and phase 2 studies that showed the initial signal of high efficacy in this particular population, and we used that information to develop the phase 3. So the phase 3 for patients 60 to 75 years of age who had AML with either a pre-existing history of MDS, so AML with prior MDS, or AML with a prior history of CMML, or therapy-related AML, meaning patients who had other cancer, breast cancer, colon, lung, got chemo radiation, and then developed acute myeloid leukemia. We call that therapy-related AML. And the last group was de novo AML, so patients who did not have a history of MDS, CMML, prior chemoradiation, but on their bone marrow they had MDS cytogenetics that Dr. Khoury highlighted. There are 8 or 9 of these published. And so these were the patients included. The study was randomized 1:1 to CPX351 versus 7+3 with the primary endpoint of overall survival. And here you see that the primary endpoint of the study was met. This is the curve on the left, and you can see that the median survival was 9.56 versus 5.95 months. And more importantly, we see that the separation was maintained at 1 and 2 years. So clearly showing that there was an improvement with overall survival with the addition of CPX351. Also, one of the key primary and key secondary endpoints was the presence of CR/CRi, and you can see that the CR/CRi rate here was improved with CPX351 versus 7+3 at 47.7 versus 33%. Now, to me as a clinician, the medians are nice, but really if you tell a patient median survival goes from 5.5 to 9.5, 10 months, this is not going to make the patient super excited. Well, it's good, but that's not what patients and what we're looking for in the clinic. So what we're looking for is 1 and 2 year and 3 year survival. And what was shown in this publication was that if you gave the patient CPX351 and took them to allogenic stem cell transplant, which really should be the goal anyways in these patients because these are all high-risk patients with a secondary AML, therapy-related AML or AML MRC, then you can see really a quite striking improvement in survival with the post-transplant survival plateauing at about 55-60%, which given that this is a very high-risk group of patients is really clinically meaningful. So I think the post-transplant outcome is really additional impressive factor that was seen with CPX, and you see it was not happening with the 7+3. Most recently at ASCO 2020, a few months ago, there was a 5-year update, and this data was really quite encouraging and impressive in my opinion. This is showing the 5-year follow-up survival, and as you can see with CPX versus 7+3 in all patients, there continued to be an overall survival advantage maintained at 4 to 5 years, and there were 21% versus 9% alive at 3 years and 18% versus 8% at 5 years. So double the number of patients at 3 and 5 years. But even more important, in those patients who got the full sequence of therapy, CPX and transplant, you can see quite impressive post-transplant survival with 50% of the patients alive at 5 years. I mean, this is really very, very exciting. And you see with the 7+3, that number is much lower, plateauing at 20% or so, which is historically what our expectation was. So CPX351 with transplant could be curative in quite a big proportion, and I think this is impressive data. What about safety? Well, safety-wise, I think it's important to note that even though CPX351 is quite effective, it is a chemotherapy formulation. And the induction mortality, even though it is lower than 3+7, is still around 14 to 15% for 60-day mortality. So we usually consider patients who get CPX351 to be approached the same way as patients who would be getting 3+7, meaning that we would admit them to the hospital, we would do close monitoring for induction, we would put them on prophylactic antibiotic, antifungal, and we would do a bone marrow usually around day 21, 28. So we should not consider, at least in my opinion, CPX351 as a low-intensity therapy. It was developed to be a more effective liposomal cytarabine anthracycline, and I think it is important to monitor the patients as you would with a traditional cytarabine anthracycline approach. What about genomics? This was a follow-on retrospective analysis of the patients treated on the CPX phase 3. What you can see is that a large majority, 60% of the patients, have a secondary type mutation. And this is quite important because when we looked at the survival outcomes in patients who got CPX versus 3+7, we see that the patients who had secondary mutations such as SRSF, splice mutations, ASXL1, BCOR, EZH, they seem to have the highest benefit with CPX as compared to 7+3. So this again is kind of biologically confirming what we saw clinically, that there is something unique about the secondary therapy related AML, it appears, that gives us more benefit with CPX351 than 7+3 in that population. We see that benefit also to some extent in patients who had the activating mutations, but it is not as prominent as can be seen in those who have the secondary type mutations and got CPX versus the 3+7 approach. So now moving to another very important topic, targeted therapies with FLT3 inhibitors. As many of you may be aware, there are multiple FLT3 inhibitors either in advanced development or approved. Some of them are highlighted here with the timelines of approval. Midostaurin is approved in the frontline setting, gilteritinib is approved in the US in relapse setting, and quizartinib is approved currently in Japan, but is being evaluated in a frontline induction study, phase 3, for potential additional approvals in other countries. So these are the phase 3 studies that led to the approval of these FLT3 inhibitors. The RATIFY study was a frontline study of midostaurin with induction therapy versus induction. The ADMIRAL and Quantum R were single agent FLT3 inhibitor versus investigator choice chemotherapy in the relapsed refractory setting. All three of these were overall survival powered and led to the approval of those agents in the respective countries. So first discussing the frontline data with midostaurin in combination with 7+3 versus 7+3. This was actually the first of the 8 AML drugs to get approved in 2017. This study was looking at FLT3 mutated patients, both ITD and or TKD mutated patients who got 3+7 midostaurin versus 3+7 induction chemotherapy, followed by consolidation high-dose cytarabine with midostaurin versus consolidation with placebo, and allowed patients to continue maintenance with midostaurin or maintenance with placebo for 1 year. Primary endpoint here, again, as with most AML studies, was overall survival. And what was shown with the overall results of the study was that the primary endpoint was met with a median overall survival that was improved. 51 versus 44% were alive at 4 years, and this led to the US FDA approval of the drug. Now again, if you look at the top line results, this data is encouraging and of course important because it was the first proof of concept targeted therapy to be approved in acute myeloid leukemia. However, the benefit is still not good enough for us to be satisfied, and we would like to see more. Here again, what was seen though is that patients who got midostaurin with induction and then got the second part of the treatment for FLT3 mutated AML, which was getting transplant, they did really quite well. So if you identified FLT3, you got a transplant consult early, you gave them midostaurin appropriately, and you took them to transplant, then you can look at 4-year survival rates of 60-65%, which actually is much better than the historical 20 to 25% 5-year survival rates that were published with FLT3 inhibitors. So again, not just adding the FLT3 inhibitor, but adding a FLT3 inhibitor and doing transplant seems to give you the best outcomes. This slide basically just highlights that all subsets of FLT3, those included TKD, those with ITD high, those with ITD low allelic burden, all had a incremental proportional benefit with the addition of midostaurin, again basically suggesting that if you find a FLT3 mutation, you should be adding the TKI midostaurin in the frontline setting. It does not matter whether it's a TKD or ITD or what the allelic ratio was, because there was benefit for all. This is very important, I think, from a pathology and molecular point of view. Let's say you have a FLT3 mutated AML patient, you gave him induction consolidation, and then 6 months later, or a year later, or 2 years later, that patient relapses, which does unfortunately happen with FLT3 mutated patients because those are high-risk patients. It's very important to not assume that that patient will be FLT3 mutated at relapse. In this study, they took patients who had FLT3 mutation, and at the time of relapse, when they reanalyzed the mutation, they actually found that almost 40% of patients had no detectable FLT3 at relapse. So many patients can lose the FLT3 mutation. Our group has published similar data, and I think it is important to check for FLT3 at the time of relapse, because you may otherwise be giving a patient a targeted therapy and the target may no longer be present at the time of relapse. Here is now another very important study that led to the approval of gilteritinib, which is a very potent second generation, highly specific FLT3 inhibitor in relapse refractory AML. This was a study that randomized patients 1:1 to receive either gilteritinib or investigator choice salvage chemotherapy. Sorry, the randomization was actually 2:1, and the primary endpoint was actually a dual primary endpoint of overall survival or CR/CRh. And here you can see that the primary endpoint was met with the median overall survival that was 9.3 versus 5.6 months. And looking at the survival curve, you can see there is quite a significant difference in survival. And the co-primary endpoint, which was response, also was significantly improved with a CR/CRh rate of 34% versus 15%. So more than double the response rate and a significant improvement in overall survival with the gilteritinib versus investigator choice high-dose chemo. And really, I think it's important to highlight this because the investigator choice chemo was usually IV chemotherapy, and in most of the patients was high-dose chemotherapy like FLAG-IDA-MEC. So if you really conceptualize this, this is single oral agent targeted therapy outpatient that actually was compared to 3-drug or 4-drug IV chemotherapy. And I think for me, even if this was equal, I would still say I like the FLT3 inhibitor because it's safer, oral, better tolerated, but this was not equal. This gave double response rates and improved survival. So really this is the gold standard to show a targeted therapy can beat 3 and 4-drug IV chemotherapy, attesting to power of identifying and targeting mutations. This was again a long-term follow-up of the study from a few months ago, showing that even with long-term follow-up, there continues to be a maintained survival. What is unfortunate though is that we do see that once we get to close to 2.5-3 years, that only 15-20%, and these are mainly patients who went to transplant, are alive. So I think gilteritinib is an impactful and effective targeted drugs, but I think to see the full benefit of it, we will have to wait for data with combinations, and many of these are ongoing: gilteritinib with induction chemo, gilteritinib with azacitidine, gilteritinib with venetoclax, and others. And I think that combination approach will really further improve not only the median, but the 2- and 3-year long-term survival. Another important point that was noted is that among patients who got gilteritinib, had a remission, went to transplant, and then resumed gilteritinib versus those who got to transplant but did not continue the gilteritinib post-transplant, there was a benefit for continuing TKI post-transplant. This is similar to data that has been shown with other FLT3 inhibitors where post-transplant maintenance, for example, with sorafenib, has shown to significantly improve survival. And at MD Anderson, we are routinely doing post-transplant maintenance with FLT3 inhibitors for all our patients. Now moving towards a separate topic, which is a major drug in AML, venetoclax in combination with HMA. This was initially approved based on the results of phase 1b/2 study, where we saw that the combination of HMA venetoclax significantly improved response rates compared to what we had seen with HMA alone, with CR/CRi rates of about 70 to 75% and median survival of 17.5 months. So based on this very, very exciting data, the US FDA approved HMA venetoclax on the phase 1b with a subsequent phase 3 study required. It's important to note that although HMA venetoclax was quite effective across the board, one subset remains high risk without great improvement with HMA venetoclax, and that is TP53 mutated, where the median overall survival has stayed at 5 to 7 months, and we think other approaches will be required. So that then led to the phase 3 study of azacitidine venetoclax versus azacitidine 2:1 randomization. This was the VLAA study. This was published recently by my colleague Dr. Courtney DiNardo in the New England Journal, actually just about 1-2 weeks ago. And this study looked at older AML patients, either those who were above 75 years of age or those who were younger than 75 but had a significant comorbidity that would put them at very high risk from induction therapy related mortality. And this phase 3 confirmed the benefit of the aza venetoclax versus azacitidine with a response rate of 66 versus 28%, so more than double CR/CRi, which was quite encouraging, and also most importantly, an improvement in median overall survival with a median overall survival of 15 versus 9.5 to 10 months. And as you can see from the survival curve, also quite encouraging that even at 1.5 and 2 year follow-up, there seems to be a maintained plateau, meaning that even in this very old population above 75, there may be now a curative potential that we really did not have before with now HMA venetoclax compared to azacitidine alone. Now moving to the last portion, population for which we still don't have yet a major breakthrough, although we have a couple of drugs that are showing encouraging positive signals. This is the TP53 AML. So we discussed FLT3, we discussed therapy in secondary AML, we discussed older AML above 75 or patients with comorbidities. All of these have moved forward with new drugs, improving responses, improving survival. Unfortunately, we cannot yet claim this in TP53, whereas you can see the survival remains very poor with median survival, even with HMA venetoclax in the phase 2 and phase 3 of only 5 to 7 months. So what are the new drugs we're excited about? There's a drug called APR-246. This agent in combination with azacitidine has been presented at the ASH meeting, and we see the response rates are quite striking, more than 85%, and also the median overall survival looks quite encouraging at 12 months, almost double of what we saw with HMA venetoclax. This is a phase 1b and we need more mature data, but definitely a promising approach for TP53 AML. And another drug is a very unique mechanism leveraging the macrophage immune system to fight against leukemia. This is targeting CD47 antibody on the surface of the leukemia cells, allowing macrophages to become unexhausted and fight against leukemia. And with this approach as well, we are seeing some very encouraging data in general in older AML, but more specifically in TP53 mutated AML, where we're seeing response rates of 75%, median overall survival, median duration of response have not been reached, and the agent seems to be very well tolerated with a 60-day mortality of 0. So both APR and magrolimab, hopefully we will have more data by ASH of 2020 and 2021, and we're hoping one or both of these agents will result in breakthroughs and approvals in TP53 AML. So in summary, I think the identification of mutational and chromosome targets is no longer academic exercise. This is something that really should be done on routine practice as part of treatment of all AML, looking for FLT3, IDH1 and 2, looking for MDS-related cytogenetic changes, looking for core binding factor and APL are the current standards. We may have a few additions in the future with potentially looking for TP53 and MLL rearrangement because there are new therapies emerging for that. But in the end of the day, appropriate selection and application of these targeted or directed agents really can make major difference, 20 to 30% or even more improvement in absolute survival. So it's quite critical for our patients. With that, I will move on to the question answer. I will take one question from the ones we have had from the audience. So one of the questions that we have here is that is there any difference in outcome with CPX351 depending on prior exposure to HMA? I think this is an important question, and as part of the phase 3, there was no predefined stratification for patients who had prior HMA for MDS or CMML who went on to CPX351. What we do see in an ad hoc retrospective analysis was that there was still benefit for CPX351 over HMA, however, it was not clearly statistically significant. I do think that once you do a phase 3 and the statistics are maintained for the phase 3, and if there is not a predefined, statistically defined stratification, one should not go back and look at subsets and see if there's a big difference because these are not going to be statistically rigid. So in my opinion, even in patients who have received HMA and progressed, I think using CPX351 based approaches is reasonable. Of course, there are many trials combining CPX351 with venetoclax, with gemtuzumab, with FLT3, with IDH, and I would encourage you to consider the patient for those trials because we believe those combinations will be better even than single agent CPX351. With that, I would like to turn it back to Dr. Khoury to close out the session, and thank you all for listening.
Thank you very much, Naval. This was an outstanding overview of where we stand today with AML therapy and how laboratory data, hematopathology information, and treatment decisions really go hand in hand. So I'm really excited to see what will come down the pike in terms of P53 mutated AML, and we'll look forward to some data along that front. So to our participants, thank you very much for joining us today. Thank you very much for joining us, and have a good day.
This activity is jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/GKC860.